Good morning, everybody. Good morning. Thank you for attending the last push, the final day, exercise in CF. I'm Ryan Harris, and on behalf of my co-chair, Danae DePilla-George, I'm Ryan Harris. Thank you. No, we're so happy to be here, and I think we have a really amazing session that you will enjoy. We have no disclosures, and I'm sure you have seen this session objectives. That's why you're all here. But first, we have a little treat. We're going to hear a little perception about exercise from individuals with CF.
Like running, walking, running.
Working out, stretching, just doing things to keep your body moving.
Mountain biking.
Yeah, sometimes.
Yeah.
Let's just say I should be doing other exercise to help with mountain biking, but pretty much only mountain biking.
Energy. Because you run around, hit ball, PE every day.
To help make my lungs stronger.
Well, overall, I exercise because it's fun. I love mountain biking. First reason is it really helps my digestive system. It just clears out my gut. It keeps it moving, stuff like that. 2, my lungs feel excellent. Like a lot of times I'll even skip a breathing treatment because it does better than a treatment. And then 3 is just overall mentally, I'll feel terrible, don't want to do anything, kind of just lazy. And then my parents will just send me out on a bike, force me to go ride a dirt road. Even though it's a dirt road, I feel amazing, and I feel like I could practically conquer the world after that. Sometimes, so a lot of times, we depends on how many treatment times I'm doing. If I'm doing 4 a day, we might only do 3 because I'm mountain biking or stuff like that.
Nope.
And it has replaced it. And it's sometimes been better than an airway clearance. The only thing it really doesn't do that treatment time does is the medications, the actual inhaled meds.
I'm just getting really tired after for my lungs and to feel stronger.
Healthier life, I'm doing it because I love the sport, and I would say this for any sport, like soccer. If you love it, you don't do it for your health. You do it because you want to do it, and then it's just another thing that helps your health. I struggle with gaining weight and stuff, because CF, burning tons of calories. When I mountain bike, I lose a ton of weight, which makes me hungry. So overall, I actually gain more weight. Yeah, I feel like I eat healthier as well, because instead of just eating a pizza for lunch, it's well, I need more protein, so I'll have eggs. I like it because it's just I don't feel as limited. CF, sometimes it's hard, but it's just gives me this sense of it doesn't matter, right? And also faster because I want to win races.
Do it so your PFT numbers can be higher. You can feel more healthier, stronger.
One, I just say do something fun in your life. Find something if you don't want to do exercise, just try out some stuff. If you like pickleball, increase in pickleball, and because it involves exercise a bit. And then also just kind of convince yourself, hey, this is going to improve my life. You're going to have more time to do better stuff because you're going to be more healthier.
Excellent. I think we could all learn something, even from these kids, Caden, Talon, and Jezebel, and really just think about this. We could educate our patients and our families that exercise is important, right? And it can be beneficial. So without further ado, we have a really amazing panel here, Lisa, Joel, and Jen. And they're going to give their talks, and then what we're going to do at the end is have a question and answer panel from the experts. So anything goes about exercise. We're going to do our best to kind of answer all your questions. But I think between all 5 of us, we could do this. So with that being said, let's start off.
So our first speaker is Lisa Morrison. She is the principal physiotherapist at the West of Scotland Adult CF Centre in Glasgow. She has worked in CF care for 29 years, encompassing both pediatric and adult care. She's responsible for the team of 5 CF physiotherapists, providing holistic care for the 350 plus patients attending a regional adult CF unit in Glasgow, with direct responsibility for their physiotherapy management from transition through to terminal care. She is the physiotherapy clinical lead for the CF respiratory unit and manages and supervises the care of the complex respiratory patients. She has developed a research forum within the CF physiotherapy department and participated in successful teaching of junior members of staff. Lisa has participated in the development of local, national, and international guidelines in various aspects of CF care. She is an author, co-author, and editor of CF Physio Cochrane Reviews. Lisa contributed to NTM National Standards of Care as part of a multidisciplinary team approach. Lisa is currently undertaking a PhD exploring the role of digital health technologies to support the future care of people living with CF. Please welcome Lisa Morrison.
Thank you very much, Danae and Ryan, for the privilege to chat to you guys today. I'm having PTSD from the day before when I got annihilated by Gemma, but I think perhaps if I'd had Talon on my Jet, Karen and I side, you might have voted differently, because he was certainly an advocate for exercise and management of CF. So I've been asked to give, I have no disclosures to mention. I've been asked to give a brief history about the value of exercise and exercise testing. So I'm going to do that. I'm going to talk to you a little bit about standards just to kind of ease in. And then I'm going to get you to hold that thought. And then we're going to jump forward and think about virtual technology, virtual exercise, and how we can use current digital health tech for the management of CF ongoing, and the challenges and considerations that they come up with. And that's for the MDT and the people with CF that are using them. Now, my daughter was very impressed when I decided to do a PhD in digital health, because she said, "Mum, you can't even cut and paste." So there you have it. So we've known for some time about the prognostic value of exercise testing. Since 1992, we've seen that if you can establish good exercise habits and have a good VO2 max, that we can extend our life expectancy in people with cystic fibrosis. And that was further explored by Helge Heberstreit in 2019, who showed that when Pat Nixon did it, it was 8 years, and he has demonstrated that, with modern health and progressive management of people with CF, that we can extend the life of people with CF if they exercise and if they maintain their exercise capacity by up to 10 to 15 years. So we're looking at improving overall health and mortality, and that was before CFTR. We've also seen just this year that if you are unable to use a metabolic cart for any reason, for example, you don't have the capacity in your service, you don't have the skills in your team, or you don't want to use it because the patient is quite uncomfortable with wearing a mask, or they perhaps have a Mycobacterium abscessus, which you don't want to cause for cross-infection, that you can use just cycle ergometry, and you get a really good measurement of, or a predictor of, lung morbidity and mortality by using peak work. And peak work was found to be equally, if not more important, than VO2 peak when you're thinking about morbidity and mortality in people with cystic fibrosis. So it's a good thing to do. And also, if we are looking at doing this in our patients, it's a bit more accessible than using the full metabolic cart in a lab. And if we look back at the standards of care, and the last ones I could find from the CFF were in 2009, and everybody's advocating exercise. This has been part of the mainstay of physiotherapy, PT and RT for some time. And again, before CFTR modulators. So aerobic exercise is recommended for patients with CF as an adjunctive therapy for airway clearance and its additional benefits to overall health. And this is from the CFF. And more recently from the ECFS standards of care. And there's a series of 4 which have considered how we look after people with CF and into their ageing. And it says in some cases it may be appropriate to consider alternate approaches to maintaining respiratory health, including the use of exercise as an adjunct to airway clearance, particularly in people with stable disease. And I think that's the key point here. We have to consider where exercise fits, and we know that it's better perhaps when people with stable disease and airway clearance are perhaps more useful in people who have variations in their health status or who have a poorer lung function. And physiotherapy advice for airway clearance, including physical activity and exercise, should begin at diagnosis. Standardised exercise should be given by the whole team, and we should support people with CF to be physically active and exercise regularly. So those are the standards of care. So, excuse me, what are the benefits of exercise testing? Well, as we heard just recently in the session next door about ageing. Well, we can use exercise testing to look at the cardiovascular risks and associated comorbidities in a person that's ageing. We know that we can get prognostic information from the CPETs or any other exercise test that you do, but primarily CPET. And we can monitor the effects of an intervention. So we can look at people pre-CAFTRI or Trikafta and post-Trikafta and see what the benefits or the differences are. It was quite a challenge for us, some of us, because in the UK, Trikafta, we call it Kaftrio, was introduced at the pandemic, so we didn't get the opportunity to pre-test everybody before we established them on the medication. So we have a dearth of information there, but I think that is coming hopefully in the future with a younger cohort of patients. And we can also use it to detect exercise-related adverse events. For example, as the patient is aging, they potentially will have aging-related comorbidities, heart disease, cardiovascular risks, and using CPET we can, or exercise testing, we can use these to detect exercise-related adverse events. And more specifically, for the patient, we can demonstrate that exercise is safe. We can motivate somebody to be physically active, and we can assist with individual exercise counselling and subsequent programming. And I think that's really quite key, because we spoke earlier in the conference about people with CF feeling better, feeling stronger, and we heard that from Talon. And we need to be able to explain to our people with CF that it's safe to exercise now in a body that they didn't know how to use before, and how to motivate them to be physically active. And using all the statements that Talon had said is, makes him feel stronger, it makes him want to eat. And similarly, one of my patients said the same in our session. So hold that thought and we'll come back to it. So what does the future hold? Well, we've seen at this conference, and I don't know if you noticed on day one when we came in, there was a whole other conference going on about medication, med devices. So there's a lot of things going on at the moment. COVID helped us explode digital health technologies, and so many more things for the use of symptom monitoring, wearables. All these things have exploded in our lives, and we're using these much more. So exercise testing, really, really useful. Park that. We'll come back to that. Tamara Vag is a researcher in Ireland who has established the telehealth working group in the ECFS. But she also has looked significantly at some telehealth references, and she had a systematic review which looked at 39 manuscripts, which looked at the effective use of telehealth in CF care, and then subsequently looked at 10 specifically that were exemplars to inform future healthcare. Oh, I didn't mean to go back so soon. So we can see here that most of them looked at, the focuses were on virtual clinics, physiotherapy, mental health specifically, because a lot of the mental health communications can be done virtually. Medication adherence, we're talking a lot about that, and symptom monitoring, reducing colonisation of Pseudomonas, treatment management, and whole body vibration. And really looking at expansion of technologies over the last 20 years, the graph just shows you up till 2019 how many more publications have related to the use of digital health. And actually that's just 2019. And as part of the telehealth working group, one of the participants did a PubMed search and found 604 references along the search string that's identified there. So there's a lot more information coming out about digital health tech and the management of people with CF. So what key points can we pull from that? Well, video conferencing, as you're probably all aware, is becoming much more commonplace. It was always in a place where people had geographically remote distances. So, for example, Australia, we've seen a lot of the information come from Australia because they have a geographically expansive area to cover. So video conferencing is much easier for people to access their services. We have a little bit of that in Scotland because we have distant islands, but it's the only way that we can be compared to Australia because, believe me, it's not the same at all. These are predominantly small studies to date. We haven't been able to study them in great depth, but if we've got 604 references, perhaps, again, these are coming through the pipeline and we'll be able to see them. And what they've shown us is that there's definite support for home monitoring. There's definite support for adherence, and we've seen that in the CF Health Hub, which has been around for some time. And we've seen it in Project Breathe, the outreach project which was discussed yesterday, HERO 2, which stands for Home Reported Outcomes, and that looked at symptom and medication reporting, and even just using Folio Health independently, a patient can access that and input their data as they choose and get information back from them. People are able to use these technologies to discuss with their clinicians when they go to a clinic consultation to say how they're feeling. They can use the data from these to say, well, actually, I can see that you're not walking as far as you used to, your step count is low, or you're not sleeping, or your lung function is deteriorating or changing in response to something. And we can use that to direct the clinical consultation and support the patient when we're talking about individualised management. But it's important to know that there's a burden of data logging, and if it's not done automatically, some people are very loath to adhere to doing the data logging. So I think we need to be very mindful of how much we're asking people to upload actively data, because if you have to actively upload, there was a 50% drop in that data. And we can definitely improve that if it's auto-logged. And we saw that from the Project Physio, where they were able to collect 5 million airway clearance interventions, but that's automatically logged. I don't think anybody would be able to upload themselves. So we saw from that using chip devices, and we're talking about digital health and those kind of devices as a supportive, then if we're using chip devices, and that includes nebulizers as well, then we can use these to support and promote adherence. We can use these to advise the individual how well they're doing their therapies and optimally. So we saw from Project Physio, you can do a lot of treatment, but if it's not proper, it's not worthwhile. So this uses us to actually guide and manage the interventions so that we can educate people to say, this is how to do it properly, and this is why we're asking you to do it. Also, it allows us to rationalise hospital visits because we don't have to have the individual coming in all the time to share data with us. If we can auto-log, it means that we can look at it remotely and advise over the phone, and we can improve our communication. So we think about virtual exercise testing. There's not really very much evidence out there for virtual exercise testing, unfortunately. And again, maybe that will change. There was a rapid review done by Anne Holland, and again from Australia, looking at home-based or remote exercise in chronic respiratory disease during COVID. And basically they found that it was an accessible and convenient alternative to face-to-face testing. The test that they used was a 6-minute walk test, and it was proven that actually there was very little difference between a face-to-face 6-minute walk and a home-based test, particularly when it was outdoors. If it was done indoors, there were some differences, but an outdoor test was okay. A sit-to-stand test was also looked at, and they felt that that was appropriate to do virtually also. The sit-to-stand test, there's more than one, and the favoured one of choice for the ECFS is the 1-minute sit-to-stand, because that's a functional exercise test, and it's not maximal, so it's able to be done remotely, because you probably are unlikely to have any adverse events, and you could witness the patient doing it at that time. And interestingly, the other one they used was a timed up-and-go test. Now, as a physio working in cystic fibrosis care, Timed up and go, I think, is something they use in elderly care. Now, we didn't have that before, but maybe that's something we'll need to think about as a patient with CF ages. So basically, timed up and go is if an older adult takes longer than 12 seconds to get up from a chair and walk, then they're at risk of falling. So I think that's important for us to think about when our patients are aging, and maybe timed up and go is something we can do when we're assessing frailty. They also looked at 3-minute step tests. Now, the validity of a 3-minute step test, it's considered that it's less valuable in an adult because it's got a low ceiling effect. Most people can manage it. So unless you have particularly bad lung function, you'll be able to complete a 3-minute step test fairly easily. However, the problem with these things is they don't necessarily reflect well with walking or allow exercise prescription. And also, if patients are at risk of desaturation, you shouldn't really do home exercise testing because obviously that person's at risk. So really prioritise anybody that you think who has low lung function or is at risk of desaturation should be prioritised for centre-based testing when that's available. There was one virtual exercise test, a 3-minute step in children, and I think this is Vendrusculu, I think, is a Edinburgh group, or she certainly had been previously, and they looked at children and adolescents and evaluated the difference between in-person supervision and remote supervised 3-minute step tests. So they had the patients in the hospital, and then they checked them 2 weeks later at home doing a 3-minute step test. There was no difference between the test results, and the physiological responses were similar between heart rate, SpO2, and the Borg scale. Unfortunately, as I mentioned, these are submaximal functional tests and limited information for those with preserved lung function. So again, you're not going to get very much out of that with our people with CF who are better now. You can't really do a maximal test at home because it's too risky. So the 3-minute step test is something that the ECFS exercise group don't suggest as beneficial anymore because it doesn't really challenge people. We are tending towards Brenda's test, which is the Alfred step, and that seems to be a much more maximal test. And we heard from Brenda the other day that it correlates quite well with VO2 max when you're looking at it compared to the CPET. So again, a test that we probably shouldn't do at home because we are maximally testing these patients. So what about virtual exercise? Well, it can be accessed from home, which is great, which means it reduces the risk of infection for patients with CF, and that's hugely convenient. There's a wide range of options available. For example, during COVID, you could see people were using YouTube, Peloton, Zoom classes. We had classes that we were delivering at our own units. And so a massive range of options available for people to do. They don't have to leave their home, so it saves time for them as well, so it's convenient. We can personalise exercise when we use virtual exercise classes. And if we're doing it for our patients virtually, we can extend it out to a wider group, and obviously risk of cross-infection is not there. And because we know those patients, we can actually look at their exercise testing as we've done previously and be safe when we're giving virtual exercise classes. And we can engage them and motivate them. It was interesting from the MRA Wood the other day when we looked at the Project Physio and gamification, and how using gamification to change the way that people can actually influence their airway clearance was phenomenal. So gamification and virtual exercise is something that we can use more, I think, in CF, because it's definitely used in neurological deficits and musculoskeletal issues. If we do groups as virtual exercise, we're going to improve socialisation and community support. We did have an exercise session during COVID, and we have subsequently run many more. And when people come to exercise together, what they do get is peer support, which they didn't have before. Unfortunately, there is always going to be the other side of the coin. So it was found by Narelle Cox that online participation was no better than usual care. They had a look at 107 people with CF over a 12-week participation and 6 months follow-up. And even with feedback and where they had a goal setting, they followed them up on the telephone, they encouraged them, they motivated them, there still was no better encouraging participation with exercise than usual care had been. However, again, people who used the digital platforms during COVID had a greater means of meeting their moderate to vigorous physical activity guidance. You know, we always drive towards that. So people who were using that during COVID were more likely to meet those. There was also another one that looked at remote resistance training, which actually managed to increase fat-free mass and strength of the lower limbs over an 8-week program. So these things are useful, sometimes not so great, but I think if we add in feedback and we add in goal setting and we structure it a little bit better and maybe supervise it, we might get better outcomes. So exercise evaluation and progression via online supervised activity with trained staff exists, but we are aware of how our people with CF exercise, and now that's possible to be able to do that and take it into the class situation. And the group activities, as I mentioned, offer peer support, flexibility of scheduling, and supervision from their own care providers, which I think gives a person a feeling of safety and education, because we can educate them in ways of doing that exercise. They don't have to explain to us what their CF means for exercise or exercise omissions where they can't do something. And I think online supervised activity definitely can help people meet their goals. And that was less significant when you have an on-demand situation. So we've been using Beam as an exercise platform. And I think when people show up, when you're there teaching, it's so much easier to keep them going and have them attend. But if you're asking them to only use on-demand or previously recorded videos, they're not necessarily engaging quite as much. But even with that, we have seen a significant drop-off in online participants. Just recently, Gemma, myself and another group from Wales tried to have a bigger super group to try and engage and increase engagement with our patient populations. And we thought it was going to be the greatest thing, but unfortunately, only 2 or 3 patients showed up. So it's still something that we're driving for, but I think the problem is our patients are feeling so well now, they've found their own exercise niche. They don't need us to support them quite as much now because they can go out to a regular gym. But what about digital health technologies? Well, we can use these for self-reporting. We can use these for symptom monitoring, and we can use them as physical activity prompts. I don't know how many of you guys have a smartwatch, but you know yourself, if you're sedentary too long, it kind of, I think it does, I don't have one, but we're not allowed to wear them at work, so I didn't think there was a point. So I think that people who wear them are given these activity prompts that it vibrates and says, you've not moved, move. So I think these kind of things are useful to help guide our patients. And interestingly, the smartwatch and wearable tech has increased by 1,444% between 2014 and 2022. And that's quite remarkable. So a lot of people are wearing and using these devices. It's definitely used more in research, and we wouldn't necessarily use it in our clinical practice, but I think perhaps that's something we need to consider. And I'm going to briefly talk about virtual consultation and its impact, but as I said, not for everybody. We have to understand the barriers and facilitators and consider the needs of the people with CF and the unexpected consequences. One of the really important things to note is that if you ask a patient or a person how much they did, they will give you an example of what that is. So, for example, patient-reported outcome measures differs greatly from the metrics that you can see from wearables. So, for example, a 60-minute gym session, how much time did you spend exercising? I went to the gym for 60 minutes. But if you looked at the device, actually how much time did that person spend in vigorous physical activity was significantly less than 60 minutes. And equally, a person might think they're not doing anything, but their device might measure that they'd at least done something. So again, this is somewhere where in exercise, something is better than nothing. And this was shown also in the Bradley Kwon article, that feasibility of using pedometers as an outcome measure showed that actually there was an improvement in health status when steps went up. And again, looking at the steps ahead one, when you're using wearable technology and collaborating with goal setting and feedback with text messaging, all participants, even in the active comparator group, increased their physical activity by 6%. And those with the feedback and the communication and extra stuff increased by 28% in steps week on week over 24 weeks. So that does show that even in our clinical practice, we can use something simple like a pedometer to encourage an improvement in physical activity with our patient group. But we have to think about what that means for the individual with CF. So we also have to think about recreational versus medical grade data. I think if you're using some of these devices for clinical purposes, we have to be careful because sometimes they're not going to give us the complete accuracy. But the recreational stuff also gives us generalized trends, and I think that's maybe more real world. There's a variance in accuracy, and that definitely limits clinical utility, and it can promote health anxiety. We see that in some of our patients who are already anxious, and asking them to do something else just heightens their anxiety. So we need to be careful. But we can support individual autonomy. And when you ask the patients, the people with CF felt that they can access real-time information, which provides motivation. They can use digitally enabled goal setting, which helps them recognise how these activities will promote positively on their patient care. And also, they have to be aware of how they can self-manage. The healthcare providers also felt that data sharing was valued by clinicians and has the potential to positively impact care, so it enables them to discuss the care and individualised care with them at a clinic. And I'm going to just jump on ahead because I'm running a bit short on time. So when we look at telehealth and remote monitoring, and I'm going to come to this in a wee minute, but we've used spirometry quite a lot as a means of symptom monitoring. And again, during COVID, most people were given a spirometry device for home use. There's been a lot of papers looking at home monitoring and the use of spirometry here in the conference, so I'm sure most of you will have read that. We can also ask people to monitor their weight at home and monitor their saturations. Virtual consultation, as I've mentioned, also reduces the need for in-person consultation, which means it reduces the time spent away from work or school. It reduces the time for travel. It reduces the financial implications of getting to the hospital, and often parking is a real problem. And if it can reduce that anxiety, that's definitely something. Cross-infection risk we've managed. The data tracking and management is fantastic. We've seen through, as I've mentioned, the HERO, the Folia Health, all these things look at symptom monitoring, and it can help the individuals with CF see how their symptoms are changing day to day, diurnally or even over a week. It does allow us to give medication prompts. We can set alarms, we can set timers, and these things are really useful for people to see where they're going right. And education and support is really important. In physiotherapy, we've used resources like education quite a lot, and things in the UK called physio tools, which now can send you videos how you're supposed to do that exercise. So these things are quite useful, and we can tap into these. And the CFF has a website, the UK CF Trust has a website. All these websites have valuable tools and information for people with CF, and they offer support groups. So we can use these virtual opportunities much more now to support our people with CF. So we're thinking about remote monitoring and virtual consultation, lung function, symptom monitoring, all real-world effectiveness, even glucose monitoring is important. And we can do that continuously now, which is potentially better than just doing a one-off OGTT. A couple of things about the spirometry, as I've mentioned, is there's definitely differences and disparity between face-to-face monitoring and home-based spirometry. So I think we have to be mindful of that. When you're coached, as was seen in the outreach, the coached versus uncoached definitely makes a difference. So if you're coached to do your spirometry, even if it's home spirometry, it's going to be better than an uncoached person, particularly in children aged 6 to 12, not so much in adults. But I think we have to be mindful of the differences in the accuracy of the devices in home spirometry versus hospital-based spirometry. But we're looking forward to the ACE trial, which will give us, if a person can input that data regularly, it's going to give us a predictor of pulmonary exacerbation, and that's the hope, that we can use this to support a person to know when they need to take additional antibiotics, when they need to address the issues that they're experiencing, and also for contacting their service. But what are the unintended consequences? Well, reduction of risk, that's a positive. Reduction in travel time, also a positive. Reduction in time off work or school. But what about the unintended negative consequences? Fragmentation of services. When you do these things remotely, maybe all the clinicians aren't there and the patient doesn't get the holistic view. You can't always do things that like sputum retrieval, bloods, body palpation. You can't do that. So these things are obviously fragmenting the services that you're able to offer. The accuracy of measurement in terms of spirometry is something I've mentioned, and the availability of appropriate infrastructure. If a patient doesn't have access to digital resources at home financially or because of where they live, we can't support them from a virtual perspective, and we need to be mindful of that. Also safeguarding. Sometimes if a patient doesn't want to be seen on the video for any reason, they'll use a telephone, and that's not great because safeguarding is a big issue in their care of our people with CF, young and old, and we need to be mindful of that. So I am winding up anyway. Challenges and considerations. I put in the green box because it's still important, but it's less important for us because we can't really influence infrastructure. But technology, access and literacy, accessibility and data privacy, these are really important things to do when you're setting up digital health. So it's important to recognise them. I can't influence that, so I'm not going to go on about it. But we do have an appreciation for non-compliance with data entry, and data uploading is burdensome. I had a discussion with a patient of mine who suggested we should be considering the relevance and the volume of data. So we should discuss that with our patients. She said that if I'm uploading data every day, are you actually going to look at it? And that's a really good point. If you have a clinic of more than 200 or 300 patients, do you have time to look at 3 months worth of data for every individual? Not really. So perhaps we need to say, can you give me the data when you're feeling less well? Can you give me the data on the first 7 days in the run up to your clinic appointment? Because it's much more manageable for them and much more manageable for us. So I think that that's something we need to be mindful of. And again, if we can introduce passive uploading and continuous monitoring, that's definitely much less burdensome. Successful interventions with online activity do exist, but supervised is better. But we need to try to integrate this for traditional care. We can't swap out one for the other because it doesn't fit for everybody. We've seen in paediatrics that most of them, well, a lot of them in the UK have reverted back to face-to-face consultations, whereas in adults we've tended to stick with this hybrid and complement traditional care. But we need to collaborate with patients, caregivers and healthcare providers for co-design. So in summary, we do have the significant potential to enhance the management of CF by providing convenient, personalised and engaging solutions. So that means exercise testing, exercise management and also symptom monitoring and personalised care. We have the opportunity to improve adherence using these tools, to extend the reach of screening for some issues and facilitate remote monitoring, and really to support the overall well-being of the individual with CF and empower them to have more of a say in how we look after them. We really do, though, have to take care to ensure that clinical effectiveness is not compromised because one size doesn't fit all. You can't assume that virtual consultations is going to meet the needs of everybody. It does for some people, particularly those that are well, but maybe not for those that are in a vulnerable state that are starting to slip. So we need to be careful of that. And we need to facilitate priority setting for people with CF. So we ask them what they need and ask them how we can look after them. And that's across the disease spectrum, not just people in CFTR modulators. These are my references, and just thank you very much to everybody that supported me, and I'll take questions after, I think. So thank you very much for listening.
Excellent. All right. Moving on to our next speaker.
So our next speaker is Dr. Joel Mermis, and he is an associate professor of pulmonary and critical care medicine at the University of Kansas Medical Center. Since 2011, he has led both the adult cystic fibrosis care program and the CF clinical research program at KUMC. He completed his residency and served as chief resident at Emory University before returning to Kansas City in 2007 for fellowship. He joined the KUMC faculty and in 2012 established the Therapeutic Development Network, CF Clinical Research Center. He serves on several local and regional CF focus committees, including Program for Adult Care Excellence, Grant Review for the Cystic Fibrosis Foundation. Dr. Mermis has been the principal investigator for more than 40 observational and therapeutic phase 1, 2, and 3 CF clinical trials. His recent clinical trial focus is on gene therapy studies centering on improving both the quality and longevity of life for all people with CF, including those not eligible for modulators. Additionally, investigator-initiated research focuses on the physiological benefits of exercise in CF, particularly in the era of modulator therapies and the evolving understanding of its long-term value of CF care. Please welcome Dr. Joel Mermis.
Thank you. Really appreciate Ryan and Denise the invitation to speak to you all today. And speaking of exercise, my son is playing a game right now, and my wife is texting me about every 5 minutes how his team is not doing well. So I'm putting my wearable down, so I don't have to hear about that. So as mentioned, today we're going to be talking about evolving care in a post-modulator world, which we've all heard a lot about during this conference. And I'm going to do my best to address the question, should exercise replace traditional airway clearance? These are my disclosures. So in thinking about this talk, obviously the focus of this talk is on modulators, the impact that modulators are having in CF. And if you think about the Jetsons and all the amazing inventions that the creators of the show predicted that actually came to be reality, it was pretty amazing. They predicted the video conferencing via phones, the robotic vacuums, and obviously, as we see here, the flying car, which, believe it or not, the first FAA-approved flying car was approved in June of 2023. My oldest son just turned 14, and he just got his learner's permit. It's horrifying to ride with him, but I can only imagine him in a flying car. But, I started in clinical practice in CF in 2010, and I'm sure similar to most of you, I couldn't imagine what was before us, what was going to happen. Modulators were just being initially evaluated at that time in clinical trials, and I really had no idea what was to come. And now here we are in a post-modulator world, looking at 144 weeks of treatment on ETI, as we see here in the open label extension of the clinical trial. And what I want to highlight here is that even up to 144 weeks, so just under 3 years, we see that the FEV1, at least for people in the open label extension of the clinical trial, have a stable FEV1, and that includes people that were initially randomized to the placebo and then started on ETI, and those who were on ETI from the beginning. So just really a remarkable achievement that demonstrates long-term stability. And as a CF clinician, that's really, to me, my opinion, the most important thing in CF and lung disease as a pulmonologist is not just FEV1 gain, but long-term stability for hopefully decades. And at least we have some insight here that potentially is possible. And additionally, looking at the CFQR, a respiratory domain that highlights people's respiratory symptoms, we see similarly a marked improvement in respiratory symptoms that was sustained throughout this just under 3-year period without real decline in respiratory symptoms during this time. And if we look at the real-world application of ETI in our patients via the PROMISE study, there's a few things I'd like to highlight here. On the let's see, I guess it's on your right, we can see up to 6 months of participants receiving ETI in the PROMISE study that they rapidly had marked improvement in their respiratory symptoms via the CFQR, to where at 6 months, a majority of patients had no symptoms with a CFQR of 100, or very mild or minimal respiratory symptoms. And what's even more remarkable about this, if you look on the other side of the graphic here at those individuals with an FEV1 less than 65, so these are people with pretty advanced lung disease, we see that over the same 6-month period, almost 80% of these individuals have no or minimal respiratory symptoms. So really a remarkable achievement, and even demonstrating that people with pretty advanced lung disease, their respiratory symptoms dramatically improve. And not surprisingly, when we look at people's therapies in the PROMISE study, for example, looking at inhaled antibiotics here, we see that at the 6-month time point, there's a significant reduction in use of inhaled therapies by participants in this study. And we know that participants tend to overestimate what's actually happening. So we can see in all of these therapies that over time there's a reduction in use. And this is throughout this conference been commented on in both the PROMISE study and others that are clearly demonstrating marked reduction in inhaled therapies in our patients. This is supported by the SIMPLIFY study, which many of you may be familiar with, which evaluated either stopping hypertonic saline or pulmozyme in people for up to 6 weeks. And this was statistically powered even at 6 weeks to demonstrate a long-term evaluation or suggestion that stopping these therapies would be safe. And what we found was that if participants stopped either hypertonic saline or pulmozyme but continued the other, there was no decrement in lung function during this time, and there was no increased exacerbation rate, suggesting that it was okay for clinicians to have conversations with their patients about stopping some of these inhaled therapies. Now, it's important to mention that the patient population in this study was very healthy. That FEV1 was near 80% predicted. So this really, I think, mostly applies to healthier patients, but certainly supports, at least for some people, stopping inhaled therapies. Lisa commented on Project Physio, and what I wanted to highlight about this study, this amazing study where they actually attached pressure sensors to 4 different ACT devices, and they monitored over 16 months 145 children with an average age of 10. They monitored over 45,000 ACT treatments, and over a total of 48,000 total participant study days were captured. But what you notice in the graphic here is very busy, but you can see clearly that over time participants are doing less airway clearance. You can see early on when they're observed as a participant in a clinical trial, they're doing more the first few weeks, and then over time you see participants doing less and less in airway clearance. Additionally, and Lisa alluded to this, that unfortunately, as evaluated by these pressure devices, almost 80% of their airway clearance with PEP devices was deemed non-effective. So not only are participants doing less airway clearance, but unfortunately it's often not necessarily even helpful if they do it. We also have seen dramatic shifts in the nutritional status of our patients, and I'm sure most everyone here is very familiar and aware of these shifts by this point. But we can see over a 10-year period from 2012 to 2022 that there's significant increase both in the pediatric and adult populations in the number of people who are either overweight or obese. If we look at these statistics more closely over the last 20 years, percent of people with CF who are overweight or obese has increased from 10 to 21% amongst children and 18 to 42% of adults who are either overweight or obese. And I wanted to highlight what I found to be a very, very interesting study that was just published in Nature Scientific Reports, where they evaluated CT scans of 66 individuals before and after they started ETI. The average CT scan was done at approximately 2 years after they had been on ETI. But what these authors highlight is that unfortunately the majority of the weight gain that they're seeing in these people is actually adipose tissue. There's very minimal muscle gain from just taking ETI alone, and you can see that in the top outer box where muscle ratio doesn't increase much, but total adipose tissue increases dramatically, and even more so in people who are malnourished before they started ETI. So this is something I think that we have to be ahead of and be concerned about. So we really have a new paradigm in CF. We have a rapidly evolving patient in front of us, someone who, to me as a clinician, is, my approach to them is dramatically different than it was just a few years ago. 92% of our patients are eligible for modulators, and that doesn't mean that 92% are on modulator. We know there are challenges there. But nonetheless, the majority of people are on modulators, and from a respiratory standpoint, doing extraordinarily well. And because they're feeling well, they're doing what all of us would do. They're going to work, they're going to school, they're raising families, they're having children. And it's wonderful to see. They're very, very busy living their lives because they're feeling so much better. And that's a wonderful thing. But as a result, they're doing less airway clearance in inhaled therapies. And in my experience, regardless oftentimes of what I suggest, they're going to do less of those treatments. But importantly, these patients remain pancreatic insufficient. That persists. And we know that by age 40% of our patients will have CF-related diabetes based upon current trends. And I think we have to be worried about the health impact of what we're seeing with ETI, particularly with some of the nutritional changes that we're seeing, an additional focus on mental health as we're seeing mental health challenges for people with ETI that have been discussed throughout this conference. So with that in mind, kind of having a sense of what our patients are like now, let's look at a couple example patients and talk about how we might focus our exercise prescription for these individuals. So the first patient's a 27-year-old male. He has one F508del mutation and then a minimum function mutation. He has a college degree, works full-time, has a desk job, so spends most of his day at a desk. He started ETI in December of 2019. He really had minimal respiratory symptoms before starting ETI, but has had a slight increase in lung function and now has essentially no respiratory symptoms whatsoever. He participated in one of our observational studies where we measured his sweat chloride, which we can see here. His weight is increased about 30 pounds to where his BMI now is above 30 in the obese range based upon BMI. His liver function tests are persistently elevated and have been for many years. Here's an actual image from his liver ultrasound where we can see heterogeneity consistent with steatosis and also increased echogenicity around the lining of the liver concerning for cirrhosis. He ultimately underwent a liver biopsy that demonstrated steatohepatitis with steatosis and areas of fibrosis, which obviously is very concerning, and so we're following that closely. He also just recently had a positive oral glucose tolerance test for the first time with a 2-hour glucose of 274. And he also has evidence of reduced bone health, particularly at his spine in the osteopenia range. And then I want to highlight one other patient and discuss how we would prescribe exercise for this individual. This is a 37-year-old female. She has G551D, so she was on ivacaftor before transitioning to ETI in November of 2019. Tried to get her therapy as quickly as we could because her health was really in decline. Prior to starting ETI, her FEV1 was 28% of predicted, and for whatever reason, she just didn't respond great to ivacaftor alone. Her FEV1 after starting ETI increased to near 40% of predicted, and she really had a period of time where she was doing pretty well. But more recently, her FEV1 has declined some. She's had an exacerbation and been in the hospital, and her FEV1 is now in the mid-30s percent predicted. But during this time, her weight has increased dramatically, up 97 pounds since she started ETI with a BMI of 39. Her liver enzymes are now persistently elevated where they were not before. She, on ultrasound, has mild hepatomegaly and diffuse hepatic steatosis with no evidence of biliary disease. She had actually CF-related diabetes diagnosed before starting ETI and was on insulin at one point in time. She's now off insulin with a CGM demonstrating that her glycemic control is really quite good off insulin at this time. And she has reduced bone density in the osteoporosis range based on her spine, based upon the most recent bone density study. So what do the CF pulmonary guidelines tell us? And Lisa alluded to these. The last were published in 2009. And they recommend exercise as an adjunctive therapy for airway clearance for all people with CF, but not as a substitute. But I think it's important in the modulator era to hear from patients and clinicians and what they are telling us. This survey from the CF Foundation's Community Voice surveyed 53 community members and 192 CF care providers. And of those, exercise was deemed to be a partial substitute for ACT. This was endorsed by community members, almost 60% of community members, and almost 70% of providers. And after starting highly effective modulator therapy, 36% of parents with children and 51% of adults acknowledged they did fewer ACT treatments. And I think now it's even beyond that, most likely. And at this time, 13% had already admitted they stopped all airway clearance therapy together. And in my personal experience, anecdotally, the rate of people who have stopped airway clearance is far beyond that now. So we really have a paradigm change about how we approach airway clearance and exercise in CF. Our patients have told us that we need to simplify the treatment burden. That's a top priority, and they've expressed that in multiple published papers. Airway clearance therapies and nebulized therapies are considered the most burdensome aspects of treatment, and that's why patients, if they don't deem clinical benefit, they can't tell the difference day to day. Most patients are not going to do it, or many are not going to do it. James Lind Alliance, which focuses on community partnerships for certain diseases, had as a top 10 priority for people with CF the question, can exercise replace chest physiotherapy? So this is really a pertinent question, and one that our patients are asking. So we have an evolving care model. In clinic, it's common for me in my clinic, at least, to have a lot of encounters where the patients don't even want to talk about their respiratory health. It may not necessarily be their centered issue that they want to visit about. And they want to talk about reduced treatment burden. But we are having more conversations about the impact of metabolic syndrome, the risk of developing metabolic syndrome, and the impact that could have on their overall health, their diabetes, liver disease, and also importantly, bone health, which I think is critically important, and the implications that these changes have on cardiovascular disease and mental health, which we're learning and need to learn much more about. And on the left here, you can see actually a recent publication showing a marked change in lipid profiles in patients following the initiation of ETI, which similarly, just the rapid increase in some aspects of the cholesterol profile, which again raised concern that metabolic syndrome may be a real risk for some of our patients. So how do we tailor exercise for these patients? Well, I think first we have to look at the evidence. What does the evidence tell us? What evidence do we have, not just for respiratory disease, but for these other comorbidities of CF, and how can that impact our exercise prescription? So the most impressive study, an attempt to evaluate the impact of exercise for airway clearance, was the Activate CF study. It was a study conducted both in the UK and the US at multiple sites. There was 117 participants randomized to 3 months of vigorous exercise or just their usual care. It included 30 minutes of strength building and 2 hours of aerobic exercise. And unfortunately, after 6 months, it was a negative study. After 6 months, there really wasn't a clinically significant difference between the two groups. Interestingly, I think it just speaks to the challenge with these types of exercise studies and the intervention, and that many of the participants in the control arm actually started exercising, which the authors didn't expect. And additionally, if you look at the FEV1 over time, there was no decline in the FEV1. It actually was stable or increased a little bit, which is not typically what we see with the history of CF. And this study was done with 90% of the participants not being on modulators. So for whatever reason, these people actually did really well, and thus there was no difference either in exacerbation rate or lung function during the study. But we do have other studies, many of which are heterogeneous and unfortunately, shorter in duration, but they do demonstrate increased peak expiratory flow, improved mucociliary clearance, and increased ease of expectoration for people with CF who exercise as a substitute for airway clearance. So there is evidence to clearly suggest that it can be effective. But one of the key things I would like to highlight and emphasize is that if an individual's going to use exercise for airway clearance, the evidence suggests that it's really important that they do some airway clearance, such as huff coughing, huff maneuvers, or PEP therapy right after exercise. And the reason for this has highlighted in this study. This was done out of a group in Australia. But what they're doing here is they're having participants inhale a radio-labeled tracer to evaluate mucociliary clearance. So these same individuals inhaled the radio tracer, they did PEP therapy, and then on a separate day, they inhaled the radio tracer and exercised. And what you see is that there is improved peripheral clearance of secretions with exercise, similar to what we see with PEP therapy, but in the central secretions, unfortunately, are not cleared effectively with exercise, and we're similar to what we see in control participants who are given the same radio tracer and then don't do any exercise or PEP. So the images you can see there on the right are just representative images of what the nuclear scan looks like as you're seeing the radio tracer leave the individual over time. So this really highlights the importance that exercise can help function for airway clearance, but it is important that some forced maneuvers or PEP are done after exercise to make sure we clear central secretions, which may remain after exercise. We really, unfortunately, have very little evidence to guide us for exercise and its effect on for airway clearance in the modulator era and in patients on modulators. We attempted to address this. And we conducted a study randomizing participants to either usual care or 3 months of coached monitored exercise, where their exercise was monitored with a Garmin pedometer and a fitness tracker. And unfortunately, we conducted this study during the middle of the pandemic, which made enrollment challenging. We targeted 30 participants initially. We ended up with 21 participants enrolling and only 14 completing the study. But what we did in those 14 participants is we did a Xenon MRI before the 3-month exercise intervention, and then a Xenon MRI after. And to explain a little bit about Xenon MRI, we used it as a surrogate for lung function. We've published studies to show that Xenon MRI is more sensitive for changes in lung function than measuring just spirometry, for example. We anticipated that patients on ETI were going to have stable lung function, and that demonstrating an improvement in that with an exercise intervention was going to be exceedingly difficult. So that's the reason we use the Xenon MRI as an alternative. And what you can see here is representative images of the participants. The bottom is the baseline, and the top is after the 3-month intervention. And essentially the black areas are areas where you can see there's inspissated secretions or lack of ventilation. And so you can see the change in some of these participants after, obviously a very small group. And so we don't have statistically meaningful outcomes that we can report on, but certainly these findings at least raise interest that exercise may be helpful even in patients on modulators. We did demonstrate that the participants randomized to exercise had improvement in their cardiovascular fitness as measured by the metered shuttle walk test. So let's talk for a second a little bit about liver disease and the increasing prevalence. The question is increasing prevalence of hepatic steatosis driving liver disease in our participants. So historically, the histologic presentation of CF liver disease is focal biliary fibrosis, but in case series of histologic case series reported, up to 70% of these cases demonstrate hepatic steatosis. So we know it's part of the pathophysiology of the disease. And there's actually been a lot of interesting conversation in this conference about the etiology of liver disease, and I think it's really our understanding of what drives CF liver disease is evolving quickly. But nonetheless, I think we have to be concerned about this in the context of what we've talked about the changing profile of our patients, and concerned about what impact metabolic dysfunction and weight gain may have on a population of people who are clearly at risk of already developing liver disease. If you look at the CF registry, you can see that by age 20, under 20% of people develop CF liver disease. Historically, when I first started practicing, the education was that liver disease typically would manifest itself in the pediatric years, and that you would typically know by the time the person became an adult if they were going to develop CF liver disease. But there's clearly evidence that that's not necessarily the case. And certainly I think won't be the case as our population continues to age. If you look at the French registry of over 3,000 patients, CF patients in their registry born after 1985, you can see that in their registry, by age 30, up to 30% of their patients have CF liver disease based on ultrasound or lab testing, and 10% have severe CF liver disease with evidence of cirrhosis. And we see this trend in cirrhosis continuing to increase as people get older. Additionally, if you look at the UK and their evaluation of patients with liver disease, looking at their registry over a 6-year period, what I want to highlight here is that of 117 people during this time period that progressed to develop cirrhosis, the majority of them were adults who at the beginning of the time period did not have cirrhosis and then went on to develop cirrhosis. So we know that more and more people are likely, as they age, going to be at risk for developing liver disease, and that it's not just a disease of the pediatric population. But we do have evidence, albeit in small studies, to suggest that lower fat-free mass in CF patients does predict liver disease, suggesting that increased adiposity and potentially metabolic syndrome is a risk factor for developing CF liver disease. This study was done in 26 individuals with a median age of 15 and showed that lower fat-free mass correlated with risk of liver disease in these people. So what do we know about exercise and its impact on risk and development of liver disease? Well, we know the central feature of steatosis is founded in insulin resistance and adipose tissue within the liver and skeletal muscle, and is a pathogenic event leading to NASH. And we know in the general population about the beneficial effects of exercise on liver disease and steatosis. We know that exercise improves hepatic insulin sensitivity, and this is obtained even with moderate exercise, independent of whether it's aerobic or resistance exercise. Additionally, there's a reduction in oxidative stress in the liver and in the vascular endothelium, and this may be particularly important in CF liver disease. We don't know yet, but in listening to the sessions on liver disease in this conference, there's a lot of concern that CF liver disease is actually driven by a vasculopathy within the liver that causes progression of the disease. And so this may be an important intervention for our patients. We know that exercise can decrease hepatic lipid content, reduce inflammation and fibrosis, and that exercise of higher intensity and longer duration tends to be the most beneficial. So we have evidence-based recommendations we can extrapolate from a broader population, but we don't have specific exercise recommendations in CF to target liver disease. But I would argue that it is our best treatment currently for liver disease because we currently really have none. If you attended the study, the PROMISE study, evaluating the impact of ETI on liver disease, unfortunately, there was really no difference in liver studies before and after ETI, after 3 years of ETI in these people, suggesting that unfortunately, at least for the population studied now, I think we don't know in kids who are starting ETI at a very young age, but at least in the population study, in the PROMISE study, ETI wasn't helpful. So exercise is likely to be our best intervention for these patients. Additionally, I want to talk about CF-related diabetes. We know its etiology is complex and different than either type 1 or type 2 diabetes, but insulin resistance is definitely a proven component of the etiology of CF-related diabetes, and one that I would argue we can impact with exercise. As we discussed, around 40% of people by age 40 will have CF-related diabetes. We have the 2016 ADA guidelines for type 2 diabetes and exercise recommendations, which actually, I want to highlight, recommend daily exercise, which is different for some other comorbidities in CF where this wouldn't be the case, and recommend up to 150 minutes per week of either aerobic or resistance training. We do have a few small studies that do suggest that exercise impacts CF-related diabetes and can help stave off potentially needing to start therapy. So in this study, 10 adolescents were studied who had impaired glucose tolerance based upon their glucose tolerance test, and they underwent 36 video telehealth supervised resistance training sessions over 12 weeks. They used dumbbell weightlifting supervised by a certified strength and conditioning specialist and an exercise physiologist. And interestingly, what they found is that after the exercise intervention, they repeated the oral glucose tolerance test, and they found an increase in 2-hour insulin production in those individuals and a statistically significant increase in C-peptide, suggesting that exercise may improve insulin or reduce insulin resistance and therefore increase insulin available in these individuals, making them less likely to potentially have a positive oral glucose tolerance test. One additional study I want to highlight here, again, small numbers, but looked at 14 individuals. They were randomized to resistance and aerobic exercise 3 days per week for 36 weeks. They did CPET at the beginning, and their exercise was tailored to the CPET testing based upon their VO2 max, ramped up to 80% by week 8. And what they demonstrated in this study was similarly their follow-up post-exercise 2-hour oral glucose tolerance test was improved with a 17% reduction in glucose excursion in participants who were randomized to the exercise intervention. So both of these studies at least give us hope that exercise can have an impact on CF-related diabetes, both on control and potentially delaying the diagnosis for some individuals. I do want to highlight we have international clinical practice consensus guidelines published in 2018 by an international community, and we have the ADA guidelines, both of which recommend 150 hours per week with daily exercise recommended. And last, in wrapping up here, I want to highlight CF-related bone disease. The etiology of low bone density in CF is multifactorial. It's believed to be inadequate peak bone density during puberty and increased bone losses in adults. CFTR does play a role in loss of bone density, and there are several other mechanisms implicated in malfunctions of both osteoblasts and indirectly a bone resorpting osteoclast that contribute to bone disease beyond just lack of absorption of vitamin D, there's definitely more to the story. If we look at the registry and rates of bone disease, we see that by age 50, about 40% of individuals in the registry are reported to have CF bone disease. Interestingly, if you look at the CDC and rates of bone density in the general population, it's shocking to me. It's not that much different. But I think we have reason to be concerned. In this study, evaluating 500 people in the Toronto CF clinic, they had over 1,500 DEXA scans over 2 years and then calculated the rate of bone loss from age 25 to 48. And they calculated a loss of near 19% between age 25 and 48 at the femoral neck and a loss of 11% over the same period at the lumbar spine. So we do see this study shows a faster rate of decline in bone density in these individuals than the general population, and importantly, a faster rate of decline in individuals who are pancreatic insufficient than those that are pancreatic sufficient. We have multiple studies that do demonstrate a positive impacts of exercise on bone density, not surprisingly. I want to highlight one of these where they used wearables and monitored average daily steps in individuals and then looked at individuals that had low bone density and those that did not have low bone density. And the individuals who were more active, who had more steps, on average had higher bone density. These challenges, I will say, these studies, I will say, though, are hard to evaluate because we tend to see that the people that are the most active are those with better lung function, and the people with lower lung function tend to have more nutritional issues, have lower BMI, and other factors which may be impacting their bone density. But I think there's no question, it's common sense, and we know this, that gravity and activity are important for bones. In this really cool study published in The Lancet, you can see that Russian cosmonauts, the longer they were in space, the lower their bone density went. And so we need to encourage our patients to use gravity and activity for improvements in their bone health. We do have a guideline, a European guideline specifically commenting on exercise for bone health, as I highlighted here, and a paper published by the US community, which comments on current knowledge and future directions, which also comments on exercise for people with CF. But I think we can get beyond these recommendations here of what we've learned from animal pre- and postmenopausal studies, which demonstrate that bone response requires dynamic rather than static mechanical stimulation. Adaptive bone response requires a super threshold intensity, so higher intensity and higher frequency. And in particular, what's beneficial is an unusual pattern of bone loading. So in other words, rather than just jogging in a straight line, random movements where you're putting strain, such as cutting or other maneuvers like that, where you're putting strain on those bones. High impact only protocols were highly effective only at the femoral neck, but not at the spine. And I think it's important to highlight that. So in summary, combinations of impact and resistance exercise provide adequate skeletal loading, and they need to directly target specific skeletal regions, particularly the spine. So in wrapping up and going back to our patients, so our 27-year-old male that we commented on, who really has no discernible respiratory symptoms at this time and stable lung function for a long period of time without any recent exacerbations. I think in him, his exercise prescription shouldn't really be focused on his respiratory disease, and it's odd for me to say that as a pulmonologist. But I think we should be thinking about these other comorbidities when we're really thinking about the exercises we want to prescribe him. We want to target what's recommended for CF-related diabetes, and specifically for low bone density of his spine to see if we can stave that off. And most importantly, for his significant liver disease, with either aerobic or resistance training, both of which have been shown to be beneficial. So this would be an exercise prescription for this participant. And I think it goes without saying, but in listening to the young gentleman when we started the lecture, you could tell how pumped and excited he was to talk about mountain biking. And the thing I've learned in partnership with patients, if they're not interested and they're not gaining enjoyment from the activity, they're not going to do it. So in the conversations, in thinking about how you're going to be strategic about what you recommend, you need to find a way to partner with them to get what they need, but also hopefully enjoyment so it's sustained. And then our last individual is we talked about is a 37-year-old female with very advanced lung disease. I think for her, the prescription needs to be much different. I think she needs to do airway clearance every day still. I worry about her not doing airway clearance, and she needs to be doing her inhaled therapies. And I would not be comfortable telling her she can only exercise as a substitute, although I definitely want her to exercise. But I think for her, airway clearance remains very important. But these are, I think, important exercise recommendations we could make for her, such as a standing desk at work to have gravity work in our favor, and improved aerobic and home workouts, since she's in particular not comfortable going to a gym at this point in time. So in summary, to answer the question as best I can, should exercise replace traditional airway clearance? I think for many patients, yes, because I think we just need to face the reality that most people with CF are no longer doing airway clearance, even if we recommend it. And we've seen all the benefits we get from exercise that you're not going to get with wearing a vest or doing PEP therapy, such as reduced incidence of diabetes onset, improved bone health, potentially staving off liver disease. All of these benefits you get, which are critically important from exercise, that you will not get by committing that time to airway clearance. Our participants our patients are busy. They only have so much time in their day, the same as us. And if they're healthy, they're unlikely going to do both. They just don't have the time. So I think in those people, using our training, being thoughtful about who we recommend exercise to is critically important and generally better for them than airway clearance alone. I took this from the brand new, hot off the press, published CF Foundation guidance, not guidelines, but the new guidance that they have given us. And they say discussion of type and duration of exercise in everyday life will likely be of increasing importance given the holistic health benefits, particularly with aging. And that's in the paper that was just published this week. So they clearly agree with, what we're seeing. The exercise needs to be tailored to individual levels of fitness and lung function using testing like Lisa discussed, and personalized to evolving comorbidities. We obviously need to study other aspects that I haven't covered, such as mental health, cardiovascular outcomes, and cancer risk. And I would be remiss to not comment on, there's still obviously a significant population of people which are important to all of us that aren't on modulators. And much of what I've discussed may not necessarily apply to them, but hopefully we'll have similar therapies for these people very soon. And lastly, I would also be remiss if I didn't mention the elephant in the room, which is exercise uptake. And we talked a little bit about that, but all this is for naught if we can't convince our patients to exercise. So I know Dr. Taylor-Cousar is going to talk to us a little bit about barriers, and hopefully we can gain some insights into how to convince our patients in clinic to keep or start exercising. And with that, I'll wrap up, and I think we'll take questions at the end.
All right. Last but certainly not least is Dr. Jennifer Taylor-Cousar, who is a tenured professor of adult and pediatric pulmonary medicine at National Jewish Health, where she serves as the medical director of clinical research services, president of the medical staff, and is co-director of the adult CF program and director of the CF Therapeutics Development Network Center. Dr. Taylor-Cousar's expertise is clinical trial design and conduct, and she has been national global primary investigator on multiple CF-TDN pharmaceutical trials, and also conducts investigator initiative research, really focusing on the development and evaluation of novel therapies for treatment of CF. She was the first investigator to describe the pharmacokinetics of sildenafil in people with CF, and that's kind of how we met and started working on some projects that she'll share with you today. Dr. Taylor-Cousar is an elected member of the American Society for Clinical Investigation. She has multiple awards too, which I'll highlight, are Emily's Entourage CF Trailblazer Award in 2022, and the Cystic Fibrosis Research Incorporated CF Champion Award in 2021. So with that, please welcome Dr. Jennifer Taylor-Cousar.
Thanks very much for the invitation to speak, and thanks to all of you for sticking it out. So I'm going to take a bit of a step back from where we were. So you heard about some ways we may intervene, and Ryan talked to you about how important it is across the body. And I'm going to talk a little bit about barriers, but I first want to provide some context. So these are my disclosures. Most relevant for this is some of the consulting work I do for some of the clinical trials that we talk about. So I'll talk a little bit more in detail on some of the things that were already touched on what is really happening in the clinic right now in the era of highly effective modulators. What are some of the barriers to exercise in CF? And then could a non-CFTR modulator pharmacological intervention actually improve exercise tolerance for some people with CF? So again, as you've heard repeatedly, the majority of people with CF, at least in high-income countries like the United States, are variant eligible for these really effective therapies that improve lung function, improve pulmonary exacerbations, improve quality of life. However, there are some caveats to this. So they work really, really well in some people. But if you go back to the original papers from 2019 in the New England Journal and in Lancet, you'll see that there are a range of individual responses in absolute change in all of the values that we are looking at in people with CF that were treated with Alex-Tezaiva. So the first one I'm showing you is looking at those people who had one copy of F508del and a minimal function variant, or a variant not expected to respond to these modulators. And the x-axis actually shows you buckets of improvement of FEV1. So you can see that placebo in gray, it's fairly tight in terms of improvement, as you would expect. You wouldn't expect them to improve their lung function without treatment. But there was a huge range that went from 0 to 30 in how people responded to Alex-Tezaiva. And you might think, well, that's because they only have one copy that is going to respond, if anything, to ETI. But even in those people who had two copies of F508del, there was still a huge range of what the response was in lung function and sweat chloride and other things. So it's not a panacea for every single person who goes on the drug. We also have certain things that we have to look for in clinical trials when we're trying to get a drug approved. So the FDA wants you to show that it improves how someone feels, functions, and survives. So there are a lot of outcome measures that are not done in these phase 3 trials that are being done in some of these other studies like PROMISE that you heard about earlier. But what we tried to do with this particular image is look at those things that we know are associated with CF and say, is it actually already shown that they're improved with modulators? Is it possibly improved with modulators? Do we have zero clue whether modulators change it? And are things worsened? And you can see that there's very little relatively green where we actually know it improves those signs and symptoms of CF. And I think particularly relevant for this talk, as you already heard a little bit about, is we don't really know how much it has an impact on musculoskeletal abnormalities. We also don't know how it impacts the increased arterial stiffness that we know exists in many, many people with cystic fibrosis. So a lot of questions still out there, even in this era of these modulators. Another important caveat, aside from the range of whether or not somebody responds and how much they respond, is not everybody who is eligible is actually on a CFTR modulator. So this is data from the US CF patient registry. On the y-axis is the number of individuals. On the x-axis is the total eligible and who's actually on them. And the different colors represent the different modulators. So if you focus on 2022, which is the only data we had until, well, this afternoon when they really announced the 2023 data, you can see that only 82% of people who are eligible are actually on modulators. We know that some of that is related to the fact that people can't tolerate them. There are side effects, including liver function, including for some people mental health intolerances, and some people who are gaining so much weight that they stop taking them. We also know that there are access issues. Obviously, these medicines cost $300,000 a year, and if you don't have good insurance, then you can't be on them. And we recently showed that if you're Black, Indigenous, or a person of color, even when you're eligible for these modulators, you're less likely to be prescribed. So there are lots of people who are not benefiting. You heard a little bit earlier about Simplify from Ryan. There's also another study called CF Storm where we're looking at what is happening with therapies and is it safe for people to stop their therapies. Again, you heard from Joel, that people in this study had really, really good lung function, but it didn't hurt them when they stopped taking either Dornase alpha or hypertonic saline. And again, CF Storm is happening where they're actually looking out 12 months. They're having a bit of a difficulty getting people to enroll because so many people have already walked with their feet, meaning they've already stopped these therapies and they can't get enough enrollment. And as you saw earlier from Joel, that people are not only applying this to their Dornase alpha and their pulmozyme or their hypertonic saline, which were studied, they're also applying it to their inhaled antibiotics and to their airway clearance. And then finally, again, access. So I said in the beginning, you hear all the time, 90% of people are eligible or taking highly effective modulator therapy. Well, again, that's in high income countries. So back in 1938, Dorothy Anderson told us that the geographic distribution of those who have CF is wide, but it's been taught as a disease for many, many years. It only occurs in people who are white. And therefore, there are a lot of people who have been misdiagnosed or late diagnosed all around the world. So it does actually occur in people of every race and ethnicity across the world. And we're increasingly recognizing what Dorothy Anderson told us in 1938. So this map from Guo and colleagues is actually showing the number of people who are diagnosed around the world. But really important for this talk about what's going on with modulators is that if you look at this map, you can see that it is nowhere near 90% of people who are actually having access to CFTR modulators. So it's still a huge, huge problem. So not everybody can get them, not everybody responds to them, and not everybody who's eligible can actually take them. I think it's important also to look at what's happening with lung health in people who are eligible and prescribed and those who aren't eligible. So again, data from the US CF patient registry, you know that in CF, prior to the modulator era, people lost lung function on average at about 1% to 2% per year. So, but what you're seeing now for those who are eligible and prescribed modulators is their lung function has gone up and it's not declining, as we sort of saw in the extension study that Joel showed you and you saw earlier. Also, we know, and we are experiencing, those of us who take care of patients, that pulmonary exacerbations have dropped dramatically. But if you look at the lung health of those who are ineligible for modulators, you can see that it's not the same story. So if you look at percent predicted FEV1, as expected, we are still seeing a decline in lung function. And while we did see a drop in exacerbations when everybody was staying home and wearing masks, it's not the dramatic decrease that we saw in people who are eligible and taking modulators. So hopefully I've convinced you that we still have a huge unmet need, both in some people who are on modulators and some people who are not. So recently, and there have been several sessions about this, we've started thinking about the comprehensive CF care team and how do we move forward in this era where we have a population where some people are getting these treatments and responding really well and some people who are not. Well, for a long time, and the way we actually improved the health of people with CF in the very beginning is by doing comprehensive care. And I think it's been very clear from this conference that we still need these comprehensive care teams. And I think particularly, again, for this topic, having physical therapists in the clinic can't go away because some people have improved their lung function a lot. And you've seen these guidelines already, so we probably need to get some updated guidelines, as you probably have realized. But again, right now, what the guidelines say is that aerobic exercise is recommended, but it can't be the only thing that they're doing. Although, again, some people with CF are already walking with their feet. So if you go back to the registry and look at this particular question, what are people doing for their primary airway clearance in 2022? So this is changing over time on the x-axis by age group, and you can see the different colors again representing what people are doing. So as people get older, especially over the age of 18, some people already are replacing their airway clearance with exercise. And then looking at this another way, so this is again looking over time at age and years, and then asking what are people doing in terms of their primary or secondary airway clearance. And again, with different age groups, you can see that it is being replaced by, your airway clearance is being replaced by exercise. And you did also hear this study mentioned. I want to point out that no, they did not see an improvement in their primary outcome of FEV1 change. But if you look at those who were getting the intervention, the supervised exercise for the first 6 months, and then they were continuing to exercise unsupervised for the second 12 months, those who were given the intervention did still have improvement in many of their exercise outcomes. And you can see, for example, that aerobic steps per day in the group that wasn't having the intervention actually did go down a lot. So it does make some maybe it doesn't make as much impact as we'd like, but having the care teams help people do this does make a difference. So I don't want you to walk away from what you heard earlier about not changing the FEV1 and say, oh, well, it didn't work at all. It did actually help improve some exercise parameters. So we need to continue to talk to people with CF about that, even if you don't have a physical therapist in your clinic, as we don't in Denver. So in thinking about the barriers, you heard a little bit about time. Obviously, there's a huge time burden on people with CF in terms of what we ask them to do. Also, sometimes people don't feel great when they're exercising, and so that's hard. And so Sam Monson is a social worker, but also a person with CF, and she readily admitted to me in clinic she hates exercise, but she knew it was good for her, as you heard from some of the kids earlier. So she's actually working on a program to help people who hate exercise, to motivate them to learn to do it basically sort of in a group setting, but virtually. But one of the things that she also pointed out that you heard alluded to is that with airway clearance, even if she does it, it doesn't give her a mental health boost the way going for a run does. And so I think that's really, really important to remember as we talk to people with CF about this, because we know actually from data in the general population that there are a lot of mental health benefits of regular exercise. From the TIDE study done by Dr. Alexander Quittner, we know that there are higher rates of depression and anxiety in people with CF. Again, modulators may make that worse for some people. And so talking to people about the mental health benefits, I think, is really important. So it can reduce stress, lowering cortisol levels and promoting relaxation. It releases endorphins, leading to improved mood and reduced symptoms of depression and anxiety. Promotes better sleep quality, which we actually have started to learn about is how it's really, really not good in people with CF. Maybe a little bit better for some, a little bit worse with some with ETI, but we really need to think about that and, again, consider recommending exercise for that aspect. It's associated with better cognition, specifically memory and attention, and improves self-esteem, resilience, and overall mental well-being. So then the question is, are there other barriers in addition to some of the things that we've talked about? So even in the setting of mild pulmonary disease, we know that exercise intolerance is actually a prevalent symptom in people with CF. And again, I think this is relevant because some people may have relatively good lung function on ETI, but they may still have exercise intolerance. We know that the rate of loss of exercise capacity in people with CF occurs at a higher rate than people without CF. It hasn't been well studied yet in the modulator era, but I suspect that we're still going to see it there. We also know that increased maximum VO2 max is associated with increased quality of life, decreased risk of hospitalization, and correlates with improved survival in people with CF. So it's really, really important, even if we don't see an immediate impact on FEV1, to continue to work on improving the ways that our patients can exercise and feel good about doing it. Some of the factors that we think may be playing a role in exercise intolerance include ventilatory limitation, obviously, in our people with really severe disease, but also decreased muscle mass and peripheral muscle dysfunction and poor nutritional status in the past. Not so much for some people now, as you saw, but there are people, again, who aren't benefiting from modulators who still don't have the best nutritional status. I think really interestingly, actually, was a study that was done by Jang and colleagues, where they were looking specifically at the role of CFTR in exercise dysfunction. So they did CFTR entire knockouts, and they also did CFTR only knockout in the muscles. And what they showed was that CFTR knockout mice have increased twist, torsion, and strain by cardiac MRI, even in the absence of lung disease. So again, this may be impacting some of our patients. So we know in the past, and you, if you're older than me and about the same age as me, you'll go back and you'll think of those patients who had horrible cor pulmonale. We don't see that very often anymore. But we do still have people that develop pulmonary vascular disease, and that leads to pulmonary hypertension. But the extent to which subclinical pulmonary vascular disease contributes to exercise intolerance and quality of life in people with CF is really not known. One thing we do know is that treatment with the phosphodiesterase type 5 inhibitor sildenafil in people without CF and other pulmonary disease, particularly pulmonary hypertension, decreases pulmonary vascular resistance and improves exercise tolerance in people who don't have CF. Also, there's some previous work that we did. We were looking at the pharmacokinetics that showed that sildenafil is actually relatively well tolerated in people with CF. So all of that led to the hypothesis for some pilot study work that peripheral vascular disease, pulmonary vascular disease contributes to exercise intolerance in people with CF lung disease, and that treatment with sildenafil in people with moderate to severe disease would actually be safe and improve exercise capacity, cardiac performance, and quality of life. So we did at National Jewish a pilot study, a double-blind, placebo-controlled pilot study examining the use of sildenafil in clinically stable adult patients with moderate to severe lung disease. We randomized people 3-to-1 to either receive 40 milligrams TID of sildenafil or placebo. And the key inclusion criteria and exclusion were that people had to have an FV1 greater than 20% and less than 70%. And somebody who had frank pulmonary hypertension was excluded because we were concerned about going off drug and having rebound. It was importantly genotype agnostic, so you could have any genotype and be in the study, and you could be on CFTR modulators, again, recognizing that even if you're on a modulator, you may still not have really great lung function and you may still have exercise intolerance. So before and after 12 weeks of sildenafil or placebo, the subjects underwent the following measures. They had 6-minute walk distance tested, as well as a formal cardiopulmonary exercise test on a bike. The secondary outcomes we were looking at were safety, quality of life, complete pulmonary function testing, cardiac strain by MRI, exhaled nitric oxide, sweat chloride, and then highly sensitive C-reactive protein to look for inflammation reductions. So these were the baseline demographics of people in the pilot study. So their average age was around 33, a mixture of genotypes. Average lung function was around 50. BMI was on the lower side for what's recommended with CF. About 70% were on CFTR modulators, but this was done before the ETI era, so it was mostly ivacaftor and Lumiva and Teziva. And baseline, they did not have frank pulmonary hypertension. Again, that was an exclusion criterion. So we showed that people, again, actually did have pretty good safety and tolerance of the drug. So there were mild to moderate side effects that were consistent with what's known of use of sildenafil: headache, a little bit of sinus congestion, flushing, some heartburn, and a little bit of epistaxis that resolved spontaneously. There were no adverse effects on blood pressure or oxygen saturations, because there has been some concern that if you start increasing blood flow that you're going to have VQ mismatch and cause desaturation, and we did not see that in any of our participants, and no changes in their safety labs, particularly their liver function tests. There was one person who withdrew for pulmonary exacerbation in each arm, and there was nobody who withdrew because of side effects because of treatment. There were also no serious adverse events outside of pulmonary exacerbations, which we know occur in people with CF. So in this study, we actually showed that over 12 weeks, people's 6-minute walk distance did actually improve when they were treated with sildenafil by about 25. We also, again, looked at quality of life, and you can see that for those in placebo black, theirs actually went down over the course of 12 weeks, but those in the sildenafil group actually went up. And the minimal clinically important difference for this test is 4 points. So you can see that they went up well over the MCID, and this is actually over what we saw with people who were treated with lumacaftor, ivacaftor in those phase 3 studies. We also looked at cardiac strain based on that mouse study that I told you, and we actually did show that treatment with sildenafil improved myocardial strain in these people who have moderate to severe CF lung disease. And we looked at some other secondary outcome measures. You can see them all listed here. This is a very small pilot study, so we didn't look at the statistical significance between these, but again, did see some improvements. Nothing in sweat chloride, which is not unexpected. So at the same time, there was a pilot study going on in Augusta, a double-blind pilot study examining use of sildenafil in clinically stable pediatric and adult patients with mild CF lung disease. People completed this randomized double-blind placebo-controlled crossover study with an acute dose of sildenafil, so not the 12-week everyday dose that we were doing, then an open label of just 20 milligrams instead of 40. The outcome measures they looked at were flow-mediated dilatation to evaluate endothelial function before and after sildenafil, phosphorylated endothelial nitric oxide synthase, and total NSO3 protein expression, and then looking again at cardiopulmonary exercise testing. So this is a busy slide, but essentially what Ryan showed, and he can probably talk about this more during the panel, is that there was actually an improvement with sildenafil treatment with endothelial cell expression, muscle function, and muscle oxygen extraction. So from these 2 pilot studies, we had reported the safety of sildenafil in people with CF and what the pharmacokinetics looked like, and then we showed that in people with even moderate to severe disease, lung function down to 20%, we could actually improve outcomes. It improved exercise tolerance, cardiac performance, and quality of life. And in mild disease, it was well tolerated and improved endothelial cell expression, muscle function, and muscle oxygen extraction. So what we really thought we needed at this point was a large multi-center trial of sildenafil to treat exercise intolerance and improve quality of life in people with moderate to severe disease. So that brought about this study that actually just finally completed. We were over there commiserating with you, Joel, about how hard it was to get anything done during the pandemic. So it took us about 6 years to get our enrollment done because of the pandemic and the pause. But I did want to take a just brief time out here to say how important it is being at this conference and going to poster sessions and coming to sessions like this and actually talking to the people that are here. Ryan and I didn't know each other before NACFC back in, 2017, when we both had posters. And we started talking about this, and then we got a $1 million funded study. So please talk to people while you're here, network. That's what this conference is for, not just the learning that you get in these sessions. So our central hypothesis for our multi-center study was really looking again at can we improve what we think is subclinical pulmonary vascular disease in people with CF by treating that pulmonary vascular disease with sildenafil. So our aims were to test the hypothesis that it would improve clinically relevant and patient-oriented outcomes in people with moderate to severe CF lung disease, to test the hypothesis that phosphodiesterase inhibitor inhibition would increase vascular endothelial function and contribute to increase in exercise capacity in people with moderate to severe disease. And then the exploratory aim was to look at whether or not it would improve skeletal muscle function and decrease pulmonary and systemic inflammation, and then contribute to improved exercise capacity. So I mentioned that we just got this done, so I'll just go through the study synopsis and our baseline demographics. So it's double-blind, placebo-controlled. Again, it's sildenafil at 40 milligrams, 3 times a day. The Revatio dose, which is what's used in pulmonary hypertension, is 20 milligrams. But in our pharmacokinetic study, we showed that that might not quite be enough for people with CF, and therefore we're using 40. We are again using people with CF who are 9 and over who have moderate to severe disease. It's a 12-week study with the primary endpoint being 6-minute walk distance, but also looking again at quality of life, cardiac strain, flow media dilatation, and NOS expression. So this is just looking at what the study design looks like. People are screened, they come in and they start drug at 20 milligrams. We give them a week to get their stabilization and their blood pressure, if they're going to have any blood pressure issues, and then go up to 40, have them come back in, and then do phone calls in between just to make sure that they're not having significant side effects. So when we looked at what our primary outcome was going to be and how many people that we were going to need, we essentially we're hoping to get around 40 people, considering dropout. Again, with the pandemic, that was incredibly hard to do. But we thought we would still have enough with that to find some statistically significant improvements if there were going to be some. So these are the baseline characteristics. So about 43% are female, average age around 31, although we did have some younger people in the study. Again, genotypes, we allowed all genotypes to be enrolled in this study. Average baseline FEV1 was around 61. BMIs, again, now we're in the ETI era, are a bit better than when we did the pilot study. The majority of people were on CFTR modulators. Again, they didn't have baseline significant pulmonary hypertension. They did have some impairment in their 6-minute walk test. There's been some controversy about using it because people think that if your lung function is great, you're going to have a really good 6-minute walk test, but that wasn't always the case here, as you can see. Looking at their baseline VO2 max, a little bit lower than you'd expect in a general population, and their baseline quality of life scores were actually pretty good, but we've seen that people with CF unfortunately have to live with this disease every day, and so their scores are a bit higher oftentimes than we think that they might be, and we know that people with CF have a lot of hope and resilience, so I think that's reflected there. So that's a commercial for next year when we'll actually present all the data that we have, because again, we just finished with the last patient last visit about a month and a half ago. So in conclusion, there is ventilatory limitation, decreased muscle mass and peripheral muscle dysfunction in people with CF, as well as poor nutritional status in some. And CFTR dysfunction itself may be contributing to exercise intolerance in people with CF. And so it persists even in this era of using CFTR modulators for many. Subclinical pulmonary vascular disease may play a role in exercise intolerance and may be amenable to treatment with sildenafil. Prior work suggests that it's safe and tolerable. And again, there is an ongoing study that we hope to present the results of to you next year. So that I'll say thanks to the people with CF and their families who participated in both these trials, collaborators, again, the invitation to speak and talk to you about this. And with that, hopefully you guys are gonna get some exercise later today if you haven't already. Let's line up here.
Great. All right. Excellent. So, what questions you guys have about exercise and CF? And if you can, just please come up to the mic and state who you are and maybe where you're from before you ask your question.
Steve Boas from Chicago. Very nice presentations. Prior to the modulators, we all struggled with what is the right dose of airway clearance, what is the right dose of exercise, standard guidelines from the American College of Sports Medicine, do they apply to CF or whatnot? I am struck by how this question still, in the post-modulator era, is very much still problematic. For some patients, they need a lot more airway clearance, more exercise. Others need less. So for the whole panel, how would you go about trying to, we talk about individualizing this, yet we've struggled with this question long before modulators came about.
Sure.
give it a whirl. It's a challenging question. I don't know that I have an answer. I think the underpinning issue for me personally in my clinic is more uptake. And what I mean by that is just getting people to exercise. And, I think our prescription as I went through the kind of exercises we want them to do is very important, but in just being realistic and practical about it all, I think we have to just take what we can get. So I guess I just say that in a practical sense of I don't know how important it really is. I think if we can convince our patients to exercise, get in a routine, then I don't know that, specifics, extreme specifics are all that important. I think we just have to look at their comorbidities, their issues, their current fitness level, their lung function, and then and use testing if you have that at your center to help guide you on the intensity of their exercise, and then do the best you can individually for that person. But I think it needs to be, I think you're going to do a better job knowing that person than probably any guidelines going to give you on how to approach it.
I think I would just reiterate that. I think we have to meet people where they are, both in terms of what they're willing to do and able to do, and might even start to talk about the social determinants of health. But if you live in the inner city next to a smog putting out building, like walking next to that building is probably not going to actually be better for your health. And so we do have to think about our individual patient that's sitting in front of us in terms of both what their physical health is, what some of the other barriers might be that are around them, and then what they're willing to do. And I think I mentioned Sam Monson's program. I think she's very much trying to individualize it, and she's hoping to get a grant from the foundation to look at this more closely. But there are some people who are going to be able to do things online. There are some people who are going to be more motivated if they're in a group of people, and there are some that are going to be more motivated if they're competing with people, like Sam's program, where basically you put in a pot of money and you start to lose it if you don't actually meet your exercise goal, but you have this accountability of a team around you, even if it's strangers. So I think it really has to be individualized. Even when we look at the Simplify results. So when I talk to people about the Simplify results, I'm like, here's what the big picture is, and here's where I think you are in this spectrum. We can't just apply all of it, even though it should sort of drive guidelines. And then also just talking with people. I still know that there are physicians, and I won't just say at my hospital, I'm sure it's all across the country, they don't even bring it up during the visit. It can't just be the physical therapist, if you have one, or the RT. I think asking every single time and making it an emphasis is important as a provider, whether you're a nurse practitioner or a physician. Like, people want to hear from us what we think is important, so we have to be willing to do that.
I think as well, trying to put it into activities of daily living is really important. I think people think when we say we want to improve your exercise tolerance or exercise capacity, we think about exercise as a structure. Whereas I think we need to encourage physical activity, which is moving. And it doesn't really matter how that's done. It could be climbing the stairs, it could be washing your car, it could be bringing in groceries. All these things contribute to metabolic equivalent of task. And I think we need to break it down for people to say, well, actually, you are doing a lot more than you considered that you were doing. And, break that down and try to make up your whatever your 1,500 METs per week that you need to do, or your 2.5 hours of moderate to vigorous physical activity per week. We can break it down that way. And it can be individualized, because some people don't like doing particularly structured exercise but are quite happy to go for a walk with their dog. And so it's some things like that we just need to try to build habits with these people so we can encourage them to participate in something that they enjoy. Because we said it in our debate that it's a fundamental thing, and fun being the operative word, really.
I'm Max Vetter from Salt Lake City, Utah. For your patients where you are decreasing their airway clearance therapy in favor of exercise, do you have protocols to help them reinitiate or increase airway clearance and inhaled therapies during times of acute illness where they're not able to exercise, or if they suffer an injury and are unable to exercise after that?
If I go first, we don't have a protocol per se, but we would always make sure that if a person was using predominantly exercise as an airway clearance tool, that they had a contingency plan if they couldn't exercise. And sometimes that takes a little bit of discussion and with the patient, because I had a similar conversation with a patient last week, and I said, if you're only exercising, what will you do if you can't go to the football? He said, I would go to the swimming pool. I said, what happens if you broke your leg? Because you can't swim then either. So it's like ensuring there's a backup plan and a contingency. We would never just say only do exercise, we've always got a backup airway clearance or a check-in with your chest at least once a week. So if you're checking in with your chest and you can see that actually you've got some secretions there, I think a wee bit like if you would then do a little bit more. You would do more airway clearance, you would check in a little bit more just to ensure that you were there. There's no protocol. We have to kind of work as an individual. If more sputum, then you have to do more physio. That's the way it works.
Yeah, I would agree with all of that. We don't have a specific protocol to answer the question directly, but just individual conversations and partnerships with patients about how to approach that if they can't exercise. I think most of our patients, the typical story you hear from your patients in clinic is, are you doing airway clearance? Well, yeah. Well, are you really doing airway clearance? Well, when I have cough, I'll do it. I'll ramp up when I need to. So I think our patients many of them are already in a mode where they're using airway clearance kind of as needed when they come down with viral illness or have another reason for increased sputum production. So that's something we definitely talk about if they're not able to perform their other modalities of airway clearance, would be exercise or other things, on how we're going to approach that, but no specific protocol beyond that.
Real quick, we have an online question that says, we hear a lot about the impact of exercise, specifically aerobic, but resistance training assists with glucose uptake in the muscle greater than aerobic exercise. Have there been any studies specifically looking at resistance training only, not aerobic and resistance, on the impact of impaired fasting glucose and impaired glucose tolerance? Just resistance training.
So that one of the studies I referenced, the primary intervention was resistance training with dumbbells that showed improved insulin sensitivity and reduced 2-hour oral glucose tolerance tests at the 2-hour mark. And that particular intervention was resistance training with dumbbells. So I think there's very good evidence that resistance training is highly beneficial for all of the aspects of all of the comorbidities that I discussed, and obviously in particular bone health, but is also demonstrated to be beneficial for the others as well. So.
Yeah, there's some really, really old inpatient data that suggested that you needed to do both for the reasons that that Joel just mentioned. Sorry, I'm going to keep doing that because I haven't enough coffee today.
Hi, I'm Gemma Stanford from the Royal Brompton Hospital and Team Airway Clearance. I really liked your talks, and I really liked the fact that you mentioned the fact that obviously huff cough needs to be with exercise because, as we know, it shakes it up, doesn't clear it. But what I wanted to ask about was the fatty liver effects. And I just wondered, have you got an idea of how long that exercise might take to affect fatty liver? So, if I say to my patients, exercise for a month, we'll get a difference. Is it a year? So when I go back and talk to them about that, what kind of tangible benefits are they going to get in what time scale?
Yeah, that's a good question. From the literature that I reviewed, I think you can safely say that you can expect to see a difference. Obviously, it's a gradual process, and to see clinically meaningful changes, for example, on an ultrasound or elastography or liver function tests, may take time, but the evidence shows that in a matter of months, you can see change there. And speaking just anecdotally of what I've seen in clinic, I've definitely seen in periods of time, 6 months or under a year, where I've had patients who had abnormal LFTs, got very invested in their nutrition and fitness, and their LFTs normalized and their ultrasound improved. So I think you can make a difference, on a relatively short period of time with exercise intervention.
And I guess I would also just say that you might see these relatively short term, but I think what you heard from Lisa is that we need these to be incorporated for life. Like, we know for a fact from old data that your survival is going to be longer if you're fit. And so this just has to be part of everyday life for the rest of their lives, really.
And we published a paper a few years ago demonstrating that a single session of exercise actually improved lung function in people with CF. But what's important about that paper and the evidence is that the intensity of that exercise, that single bout, So the higher ventilation that the participant achieved, the greater benefit they had in their lung function.
Brenda Button from Melbourne, Australia. Thank you to all of you for fantastic presentations. What do I go back and tell my patients about sildenafil use in clinic? What is the take-home message clinically?
Well, I think the take-home message is that Ryan and I have a lot of work to do over the next 6 months in terms of analyzing our data. But honestly, we do have people in the U.S., because sometimes we have flexibility with insurance companies. We have been able to prescribe it for people based on our pilot data who have really severe lung function impairment and just like feel horrible when they exercise, and it has made a difference. So I think it's going to be harder probably outside the US with payer systems being different. But we have been able to use it successfully in people, and hopefully we'll have data confirming what we saw in the pilot studies in the next 6 months.
Yeah, I think the hardest part is jump-starting these individuals to engaging in exercise. And kind of that's what we're thinking of with sildenafil. If we could increase the blood flow and increase kind of the supply and make exercise maybe easier at the onset, it could be a jump-start. We don't anticipate these individuals being on sildenafil forever, right? And so it could just be a Kickstarter.
I have a question. I don't know, is sildenafil generic yet, or is it still all? I was going to say it's gone generic, yeah, so it's at least more affordable than it used to be.
It's a lot cheaper than Alextezide.
Yeah, right. Yeah. That is.
Well, I think we went over a few minutes. I want to thank you all for staying till the end, and thank our speakers who really made this session what it was. Thank you so much.
Thank you.